We are live.
A very warm welcome to iFocus Online Lecture 5112, the fourth in Eye in Systemic Diseases. Today we have Dr. Akshay Badakere from Nethralaya, Chennai. He completed his MBBS from Adi Chunchanagiri Institute of Medical Sciences, Belur, Karnataka, went ahead to do his MS Ophthalmology from Minto Regional Ophthalmic Institute, Bangalore, Karnataka. He's also an awardee of FRCS Ophthalmology, Glasgow. He did his fellowship in pediatric ophthalmology, strabismus, neuro-ophthalmology from the esteemed Institute of L.V. Prasad Eye Institute, Hyderabad. He is currently the senior consultant in Department of Pediatric Ophthalmology and Strabismus, Nethralaya, Chennai. He was the consultant ophthalmologist at Sight Institute, LVPI, Hyderabad, the head of Comprehensive Ophthalmology Program, education in charge, clinical in charge, and medical auditor at Jasti Veeran Ramanamma Children's Eye Care Center. He has several research projects, including 30 indexed publications. He's a reviewer for both national and international journals. He's presented at several national and international conferences as well. And the most important thing of this is that he's the fitness enthusiast, a certified level 1 kettlebell trainer. It's a pleasure to have you, sir. Over to you.
Thank you so much. Thank you. First and foremost, I would like to thank you, Ashwita, for the warm introduction. And I think iFocus Online has been a tremendous platform for all of us, not just postgraduates, but even for us when we want to learn about something, we come online and we look at the lectures that you people put up, and they're very useful and it's really helped us. With that, I'll start sharing my screen. Just let me know if it's visible.
Yes, sir.
It's in slideshow mode, right?
Yes, sir.
Okay. So I would like to begin by thanking Dr. Santosh Honavar, Dr. Mahipal, and Dr. Partho for deeming me as someone responsible to take this lecture, which I'm very fond of this topic, and it's my passion. So let's see if I can do some justice to it. So I don't have any financial disclosures, and consent has been taken for all the clinical photographs. So I'll begin with these are the objectives of my presentation. We'll look at why we need to look for syndromes, and then we'll go part by part. Each part of the eye will look at a few cases and what syndromes we came up with, right through cataracts, lenticular abnormalities, aniridia, refractive errors, extraocular motility, posterior segment conditions, and then we'll end with a seemingly routine case, but came with a surprise. Now, why do we look for syndromes? If we see the firsts in all the different modes of inheritance, whether it's autosomal dominant, autosomal recessive, X-linked recessive, X-linked dominant, or the mitochondrial diseases, the first diseases that were identified in these modes of inheritance, the eye is involved in all of them. So if as ophthalmologists, we are in a position of great responsibility wherein we can actually pick up syndromes in children and take full care of them. And I think it is not correct to just look at a child as a pair of eyes. We need to look at the child as a whole. And that is something we are uniquely privileged to be able to do as ophthalmologists. In fact, retinoblastoma was the first human cancer gene to be cloned. So now you know how important the eye is when it comes to diagnosing syndromes and systemic diseases. So with that, let's begin with the first case. This is a 2-month-old baby girl, and she was brought by her parents because they noticed whitish opacities since birth in both eyes. This was a full-term normal delivery. The mother had fever in her first month of pregnancy. There is no family history of cataracts or any cataract surgery in early childhood in the family members. Elsewhere, a torch titer profile was done where her rubella IgG titers were raised, and they had also done a cardiac workup which showed presence of a ventricular septal defect. Coming to examination, this is the nature of the cataract that the baby had. You can see there's a very dirty white or yellow looking cataract with a microcornea and a partially hazy cornea. If you look closely at the iris, there is no pattern to the iris. It's completely bald. There's loss of iris crypts, and because of which it is poorly dilating. The B scan was within normal limits. So if you put things together now, the history of fever in the mother, the VSD history, and if you the torch titers and the clinical features that you see, especially this dirty white or yellow looking cataract with a poorly dilating pupil, our provisional diagnosis here was that of congenital cataract due to rubella sequelae. So coming to congenital rubella syndrome, we see this in about 0.01 to 0.8 per 10,000 live births, and it affects every part of the eye. So you can have microphthalmos, you could have a cloudy cornea. As we saw in the clinical photograph, you can have iris anomalies. The kind of cataract that we see is typical, a pearly white or nuclear cataract, what we call as a dirty yellow cataract. These children are prone to glaucoma. They can have what is called as the salt and pepper or the pigmentary retinopathy. And this, important to know, is that the salt and pepper retinopathy actually does not affect the vision of the child. They can have optic atrophy and strabismus. 80 to 90% of the transmission happens within the first trimester. That's why that history of fever is so important. They can either be stillbirths or you could have a normal appearing infant. And for us, what is very, very important not to miss, apart from cardiac, most people will not miss cardiac, the malformations or taking care of the eye. But something we should not miss is the fact that we should ask for whether their hearing screening test for hearing has been done, because sensory neural deafness is actually the commonest permanent sequelae in children with rubella. And you might take care of everything. You might refer the child to a cardiologist, you might do a very good cataract surgery, but you'll still, when you see in the follow-up period, the child's milestones wouldn't have picked up very well. And why is that? That's because oftentimes the hearing component is missed. So please remember, sensory neural deafness is the commonest permanent sequelae in congenital rubella syndrome. Apart from this, they can have intellectual impairment, they can have hematologic abnormalities like thrombocytopenia, hepatitis, hemolytic anemia, and they're prone to endocrine disorders. So we looked at one aspect of cataract and infections. Now let's look at another case where some key points in history can tell us what the underlying syndrome is. So this is the story of a 6-month-old boy referred for bilateral cataracts. In history, we came to know that the child had a very delayed and weak cry. And because of this, he needed supplemental oxygen, was in the NICU for 4 days. He was chubby and had frontal bossing. He had total lenticular opacities in both the eyes. Ultrasound V scan showed an attached retina. Now, importantly, when we screen the mothers, now this is very important to do. If the child is accompanied by parents, please do a quick slit lamp examination of the parents as well. The mother had these punctate opacities in both the eyes. You can see the lenticular opacities that are there in both eyes. Now, because of the weak cry, the frontal bossing, and the fact that the mother had these punctate opacities, we referred the child to a pediatrician. The pediatrician actually told us that the child had hypotonia. So what does this mean? That if you put 2 and 2 together, this is a child with cataract with a Lowe syndrome. So Lowe syndrome, as we call it, is actually the oculocerebrorenal syndrome of Lowe. This is a triad of congenital cataract, intellectual disability, and proximal renal tubular dysfunction. And in fact, muscle hypotonia is the first clinical symptom that gets picked up in the child. This is an X-linked recessive inheritance due to mutation in the OCRL gene. 2/3 happen via female carriers, and female carriers have these punctate length opacities which we had in our mother. What is important to know is that at different stages in the child's life, there can be different symptoms or complications of Lowe syndrome. So if you see in the neonatal period, it is generally cataract and muscle hypotonia, absent reflexes. There, if you do the biochemical workup, their creatinine kinase and LDH levels might be raised. And their renal symptoms start around 1 to 3 months of age, where they develop this Fanconi syndrome. And if you go through down the list of this table, you'll see that unfortunately they develop end-stage renal disease, and many times this could be the cause of mortality if they do not get surgery in time. So they might require a replacement later on in life, organ replacement. We looked at two syndromes associated with cataracts. Now let's look at something little more common that we see. This is ectopia lentis. Now this is a case of a 10-year-old boy who had difficulty in reading from board and printed letters. His visual acuity, as you see, is very poor. It is counting fingers at 2 meters. On general physical examination, he had arachnodactyly, a large arm span, high arched palate, and his undilated refraction was minus 12 diopter sphere with minus 4 cylinder at 120 degrees and minus 10 diopter sphere with minus 5 diopter cylinder at 140 degrees in the left eye. On slit lamp, he had subluxated lenses in both eyes. He had a superotemporal subluxation with iridodonesis. However, the zonules seemed intact. On posterior segment, his discs were fine, retina was attached, and importantly, he did not have a tessellated fundus. So if you see high myopia and see a non-tessellated fundus, please always think of the lens first. You think of the myopia being lenticular. So our clinical impression was ectopia lentis with Marfan syndrome. So we advised a 2D echo and a pediatric cardiology consult. When he came back with the echo, he had trivial tricuspid and mitral valve regurgitation. There was no aortic root dilatation. He's been presently given glasses, and the family has been counseled that the child would need intraocular surgery later on. Let's look at Marfan syndrome. This is an autosomal dominant disorder with skeletal, cardiovascular, and ocular manifestations due to mutation in the fibrillin gene on chromosome number 15. Now, the ocular features include ectopia lentis. This is probably the most common feature in Marfan syndrome. Along with myopia, they could have iridodonesis, phacodonesis, and their dilated pupillae actually don't function too well, and that's why they have poorly dilating pupil. They have hypoplasia of the dilator pupillae, and they could have giant retinal tears leading to retinal detachment. Coming to the systemic features, they are tall in stature. They have pectus excavatum, scoliosis, arachnodactyly or long fingers. They have hypermobile joints, and these two, the next two which I'm going to mention, are what we actually need to make sure we look at. That is aortic root dilatation and aneurysm of aorta, because these can lead to death later on if not picked up on time. That is why when you see a case of Marfan syndrome, please do refer the cases to a pediatric cardiologist so that they can do the cardiac workup. And many times they have mitral valve prolapse leading to regurgitation. So a timely referral can also help them lead better quality of lives. We looked at a range of lenticular disorders where either there was cataract or there was some malposition of the lens. Now let's look at the case of the mysterious whorls. This is the case of a 7-year-old boy. He actually came with no ocular complaints. I have hidden a little bit of history in this slide because let us see later on how history helps in putting things together along with ocular findings. He had good vision acuity, 6/9 N6, cycloplegic refraction, didn't really reveal any refractive error as such, orthophoric with full and free ocular movements. His cornea is clear, but if you look at the lens, when I saw him, there was a small fold on the capsule. Now, I honestly didn't know what this fold was. His posterior segment was sharp and retina, the foveal reflex was sharp and the retina was attached. But there was something else in the history that we will come at. So you look at the fundus photos are absolutely fine, compact fovea, disc is okay, retina is attached, and the left eye lens is normal. So that similar, that small fold of the capsule that I was seeing in the right eye, I'm not able to see similar findings in the left eye. Now this is where history helps. Now this child had actually been referred by a nephrologist. Since the child had hematuria since 1 year, he was treated with angiotensin converting enzyme inhibitor enalapril, and ever since treatment was started, since 3 months, he did not have any hematuria. He also had an NGS sequencing done, which showed that he had a COL4A5 gene mutation. His hearing tests were normal. So now if we look at that whorl or the fold on the anterior capsule, you look at the history of hematuria and the mutation that's involved, we know this is a clinical diagnosis of Alport syndrome. So Alport syndrome occurs due to mutations in genes that code for type 4 collagen, that is typically the COL4A345. Collagen 4 is the most abundant protein found in the basement membranes and is responsible for the membrane strength and integrity. And this type 4 collagen exists as a heterotrimer in a triple helix formation containing glycine subunits. Most of the inheritance occurs in an X-linked recessive manner, almost 85%, and 15% can be autosomal recessive. Now, depending upon which part of the in X-linked recessive patterns, depending upon which part of the terminus of the gene is involved, whether it's the amino terminus or the carboxy terminus, you can have different clinical manifestations. So if it's the amino terminus, typically you will not have too many ocular features, and the disease also is not very severe. But if it's in the carboxy terminus, you can have renal failure and a lot of other ocular manifestations, which we'll come to in the following slides. So in the ocular features, the lenticular features are these whorls or the breach in the anterior capsule. So what I thought of was a fold on the anterior capsule actually represents a breach in the anterior capsule. Apart from this, they can have lenticonus and anterior subcapsular cataracts. Another thing to keep in mind is supposing there's a child who comes with a spontaneous breach in the anterior capsule, a break with total cataract, always bear in mind that this could be a manifestation of Alport syndrome again. So the lenticular manifestations, you can have anterior lenticonus. This is a conical protrusion that occurs through the weakest part of the capsule. This occurs because of absence of the alpha 3, alpha 4 and alpha 5 network of collagen from the capsule. And because this is actually the tougher part of the collagen, this is what gives the capsule their integrity. So if this is lacking, then there are partial splits that can rupture. And when it ruptures, it develops into cataract. These are usually seen in the middle age after onset of renal failure, and because of the changes in the lenses that are happening, the patients can also have difficulty in doing near work because of the abnormal lens shape. And many times these small changes in the lens might be enough to mandate a lens extraction and IOL implantation. Coming to the corneal manifestation, again, the culprit here is the collagen because the alpha 3, alpha 4, alpha 5 network of collagen is lacking, which would give it integrity. The structures, the different parts of the cornea are poorly adherent to each other, resulting in these vesicular lesions. Coming to the retinal manifestations, now retinal manifestations are also important to know because you can either have a central fleck retinopathy or a peripheral fleck. Now, although the peripheral fleck retinopathy is more common and probably doesn't do anything to the vision, it is the central fleck retinopathy which actually tells you that this patient could have early onset renal failure. So it's important to look for these findings. You could also have temporal retinal thinning and very rarely macular holes. Now, our role as ophthalmologists become crucial because supposing we do see a case of, say we see a case of Alport syndrome, but at the moment there are no gross ocular findings that you are seeing, or no gross systemic findings that you're seeing rather. Please pay keen attention to the ocular finding that you may come across, because if you're seeing PPMD, that is posterior polymorphous corneal dystrophy, lenticonus or central retinopathy, then their chances of developing renal failure are that much higher, early renal failure are that much higher as compared to any other finding. So if we pick up these findings and refer them in time, then we are doing a lot of good for the patient and living up to our responsibility. So how do you manage these cases? A keen clinical exam and appropriate referral are the backbone. Supportive measures for ocular conditions. Cataract surgery when indicated. Do not forget refraction. Many times all they may require is probably a good pair of presbyopic glasses or correct refraction and spectacles. Once you refer them to a nephrologist and they start them on either ACE inhibitors or angiotensin receptor blockers, this can actually help to manage the proteinuria. End-stage renal disease would require dialysis or kidney transplant. So we looked at some disorders that happen in the lens and some systemic associations. Now let's look at its close neighbor, the iris. This is the case of a 6-year-old girl who had difficulty in reading from the blackboard. Her parents had brought her because of unsteady eyes noted since 1 year of age. Her visual acuity is 6/60 and N18, and she has a pendular nystagmus. If you look at the anterior segment photo here, you will realize that she has aniridia and with some punctate lenticular opacities. Her posterior segment had healthy disc and vessels. There was a dull foveal reflex, which was confirmed, and she was confirmed to have foveal hypoplasia on OCT. So coming to aniridia, Aniridia is actually a panocular condition. So it's not just, we shouldn't just look at it as an absence of iris, but it's actually a panocular condition. The most common mutations are the PAC6, the FOXC1, PTEX2, and CYP1B1. And recently, the FOXD3 and TRIM44 have been implicated. I said it's a panocular disease, and I say that because if you look at this table here, it shows you that it can cause a host of ocular manifestations. So you can have extraocular manifestations like nystagmus, and you can have intraocular features like cataract, glaucoma, aniridia-associated keratopathy, dry eye, foveal hypoplasia, as we saw in our case, and optic nerve hypoplasia as well. In fact, up to almost 90% cases of aniridia will have nystagmus. Many a time this is due to the underlying foveal hypoplasia. So if you see even in this table here, studies indicate almost 87 to 90% of cases having foveal hypoplasia and almost 95% of cases having nystagmus. So it's a truly a panocular condition. So what are the systemic associations or syndromes we should know of? If we are seeing a case of sporadic aniridia, please make sure that you rule out the Wager syndrome. So Wager syndrome stands for Wilms tumor, aniridia, and genitourinary anomalies. They could be cryptorchidism, streak ovaries, or ambiguous genitalia. And if the child is obese, then he comes under something called the Vagro. Or they could also have Gillespie syndrome, which is aniridia with cerebellar ataxia and psychomotor impairment. So if you want to rule out Wager syndrome, what do? You can either ask for a genetic test, look for a PAC6 mutation, or if you don't have a genetic testing facility available or the patient cannot afford genetic testing, simply get an ultrasound abdomen done for the child every 3 months up till the child is about 7 years of age. This way we can, in case there is a Wilms tumor developing, it can be picked up on time and treated. Coming to refractive errors and syndromes, now refractive errors are probably something we see every day in our clinic, and nowadays with the myopia that is there, we see a lot of myopia cases in OPD. They take a lot of chair time, and it's very easy to, at the end of a tiring OPD, to just dismiss these cases as myopia. But we'll come across two cases here where they're anything but simple myopia, which would take up a lot of chair time. So this is a case of two brothers, one 11-year-old, one 8-year-old, both using glasses since early childhood. There is no history of prematurity. From where they had been referred, they had been started on low dose atropine with a hope to kind of stabilize the progression of myopia. They have good vision with their glasses. They're using -15 diopter sphere, and their best corrected vision is 6/9. Their anterior segment is within normal limits. But what we saw in when we examined them was they had mid-face hypoplasia, low-set retroverted ears, a long philtrum, upturned tip of the nose, and they had knee valgus. Both the brothers had knee valgus. Coming to the posterior segment, this is the first brother, the 11-year-old. You can see the fundus photo. Apart from the fact that it is an extremely tessellated fundus, what you're seeing is a beaded vitreous, and you can see a lot of lattices in the periphery. You can see these perivascular lattices that are there, which are seen well on the autofluorescence as well. And if you look at the younger brother, again a similar fundus picture, a lot of lattices, a lot of vitreous beading. So when we saw this clinical picture, our initial diagnosis was that this is definitely a high myopia being a syndromic myopia. And the phenotype, the clinical phenotype was that of a Stickler syndrome. So if you look at the facial features, the flat nose, the low set ears, mid-face hypoplasia, along with the knee valgus and the fundus picture that we see, this was clearly a case of Stickler syndrome. Or so we thought. So we sent them for genetic testing and for systemic exam. What are the indicators of syndromic myopia, or when do you suspect syndromic myopia? So the International Myopia Institute has come up with this wonderful paper. They come up with this white paper series, which are very nice to read. What they say is that if the myopia in age is greater, myopia and diopters is greater than the child's age in years, with at least one of the following features. So your vision acuity is bad, it is not improving with refraction over time. They're complaining of poor night vision. or they have nystagmus, color defects, retinal degenerations. OCT is showing some pathology. You're see getting some irregular red reflex or scissoring, or there's history of genetic anomalies in the family, or in the family history you're getting high myopia, visual impairment, history of retinal detachment, cleft palate surgery. All these features, any one of these features is there, along with the myopia and diopters being greater than the child's age, then you definitely have to look for syndromic myopia. The pedigree charting of these two brothers also revealed that there was an autosomal dominant inheritance pattern. All these cases that we have marked had high myopia. We did genetic testing, which came positive for two mutations. Important to know that the call to A1 is for Stickler syndrome. The same for both the brothers. You can see here the same paper, they talk about the different types of genes that can be involved in Stickler syndrome, and what we got in both the brothers, the call to A1, has this typical membranous kind of vitreous anomaly that we had in the fundus picture. When they came back from the systemic exam, both of them had reports with them which suggested dilated cardiomyopathy. Now, this is where it becomes a bit interesting because our clinical phenotype, the fundus picture, and even one of the genetic tests suggested Stickler, but this cardiac involvement and the fact that they had an AML1 mutation suggested Alström syndrome. Alström syndrome we need to really look for because they can have renal pulmonary issues which can be fatal later in life. So we have planned to go ahead further testing with our genetic testing. So segregation analysis and the mutation specific testing will be done for the family members. So what I wanted to highlight with this case was that sometimes seemingly innocuous high myopia may be anything but that. So we need to actually know what are the pointers towards syndromic myopia. So we looked at a lot of intraocular findings. Now let's come to something extraocular. So on external examination, you can see this 8-year-old girl sitting with a large right face turn. She has an outward deviation of the eyes. I'll come to the 9-gaze photo very shortly. She has a right face turn of about 10 to 15 degrees and a left head tilt. Her stereopsis is about 100 seconds of arc. And if you look at the 9-gaze photo, you can see that in the left eye, there's an incomplete adduction with a large upshoot. There's an incomplete abduction as well as in the left eye. These are the further details of the clinical findings. So what she had was a Duane retraction syndrome type 3 with exotropia with grade 1 retraction and a grade 3 upshoot. Now you may wonder why Duane retraction syndrome is coming up in this. I'm not included this just because it ends with syndrome, but because Duane retraction syndrome has a lot of other ocular and systemic associations. We may not probably see this as often as, say, congenital rubella syndrome or some of the syndromic myopias, but very often these cases would end up having small either periocular tags or findings like a limbal dermoid or something which would be suggestive of a golden hair syndrome. So if you see right from extraocular different kinds of ocular manifestations involving the anterior and posterior segment to non-ocular, and some syndromes can be there with Duane retraction syndrome. This is not to suggest that Duane retraction syndrome causes all these. These are associations. So when you see a case of Duane retraction syndrome and you see these associations that are there, we shouldn't be surprised. Let's move to the posterior segment now. Here we'll look at some optic nerve conditions and a case of retinitis pigmentosa, which was a syndromic retinitis pigmentosa. So this is a 11-year-old boy who presented with poor vision in the right eye. In the left eye, he had 6/6 N6 vision. He had an RAPD in the right eye, and on Krimsky test, he had 40 prisms of exotropia. This is the picture of the right eye disc. If you can see, there is a tuft of glial tissue that is hiding the disc. It's almost impossible to see the disc. And the left eye is absolutely normal. So this is a congenital anomalous disc, what we label as a morning glory disc, named after the morning glory flower. In morning glory disc, the vision tends to be really poor. Up to 30% cases may have 20/30 or 6/12, 6/9 vision. Look for hypertelorism, cleft lip and palate. And importantly, when you see a case of morning glory disc, please image these cases. Get an MRI brain in orbit done, because there can be a lot of associations like encephaloceles. You could have agencies of the corpus callosum, and it's very important to add MRA also with your MRI, because they could have moyo disease, which is an abnormal narrowing of cerebral arteries, and this is one of the causes for stroke in the young. So if you do an MRI with MRA and it picks up this moyo disease, you can do a timely referral and prevent stroke-like issues in the young. The next case, this is an 8-year-old boy who came with diminished vision, noticed by parents since 4 years of age. His vision acuity was 6 by 60 in the right eye, 6 by 36 in the left eye, not improving with pinhole, and very short statured. So again, when you see a case, bilateral vision impairment, not improving with refraction, short statured, that is a sure shot sign that we are dealing with something that involves more than just the eye. We did a dilated fundus exam, and you can see here. Now, you might look at this and feel that the discs are okay, but actually, this is not the border of the disc. This is the optic disc, the small thing that you see here. Okay. So, what we are dealing with is a case of bilateral optic disc hypoplasia. We got MRI scan done, MRI brain done, which showed an absent septum pellucidum. And after an endocrine workup, it was found that he had decreased growth hormone levels and he has been started on hormone replacement therapy. So optic disc hypoplasia can either be an isolated anomaly or it can be coexist with ocular and systemic abnormalities. Very often there are midline abnormalities of the brain and agencies of the septum pellucidum. So when this agencies of septum pellucidum is there, we call it as Duane syndrome. And what is important to know is that they can often have hypopituitarism. Now, one may ask why as ophthalmologists should we be worried about hypopituitarism? Imagine a scenario where the same child, he's come for a squint surgery, okay, and you put him up on table without having worked him up for his endocrine levels. He could actually go into shock because his many a time their adrenaline levels and cortisol levels could be low because of hypopituitarism. So this child may end up, you may end up losing the child on table. So it's very important to see, when you see a case of optic disc hypoplasia, an MRI imaging and appropriate endocrine or neurology referrals are extremely important. Apart from the fact that you may come across, say, growth hormone deficiency or a thyroid hormone deficiency, where by giving them that complete care, you're improving their quality of life. So in the posterior segment, we looked at optic nerve. Now let's look at a case of RP, which was a syndromic case. Now this is a 6-year-old boy, unable to see well in school, difficulty in finding toys in dim illumination. On general observation, he seemed to have intellectual impairment. He was obese. And if you see, he has a small little digit here as well as on the feet. So this is known as postaxial polydactyly. So postaxial polydactyly basically means the extra digit is on the ulnar side. So in this case, you can see the small malformed little finger that's there on the ulnar side, also on the toes. So this is a case of postaxial polydactyly. His vision was poor, 6 by 60, N by 18 for near. Post-cyclopegic refraction revealed a little bit of hyperopia. And this is the fundus picture. So you can see bony spicules, pale discs, vessel attenuation. Okay, so and when you put your clinical findings together of obesity, post-axial polydactyly, intellectual impairment, we are working with a case of Bardet-Biedl syndrome. So Bardet-Biedl syndrome is a multisystem non-motile ciliopathy. It's an autosomal recessive condition, and there are 26 known genes which can be involved in causing Bardet-Biedl syndrome. The most common is the BBS1. Now, when you diagnose this, there are actually major and minor criteria to which are there. They are the major criteria being central rod dystrophy, cone rod dystrophy, central or truncal obesity, postaxial polydactyly. So if you see and cognitive impairment, all these four were present in our case. Hypogonadism and renal disease or malformations. And minor criteria could be neurodevelopmental issues, anosmia, hyposmia, dental anomalies, cardiac and thoracoabdominal defects, and endocrine and metabolic defects as well. So increasingly, we are seeing through all our cases that there is multi-system involvement in a lot of these ocular conditions. So this is the last case. I said I would be finishing with a seemingly innocuous case but full of surprises. Let's see what this is. Now, this is a 10-year-old boy, and oftentimes in our clinic, many times the parents cannot accompany the children, especially from very far away, from the farming community or something like that. So this was one such case, 10-year-old boy, accompanied by his uncle, he was actually referred for nystagmus. He has reasonable visual acuity, 6 by 12 in the right eye, 6 by 9 in the left eye. Always good to do binocular vision in children with nystagmus. He's read 6 by 9, N6. Not much of a refractive error. Extraocular motility is full and free. He had a very small amplitude, very subtle kind of nystagmus and no abnormal head posture. His pupils were fine. So we may look at this and say, what's the big deal in this? Look at his slit lamp. Now, when you see his slit lamp, do you see these small nodules here? These are leash nodules. So when we saw this, we decided to just examine him in detail, and you can see these huge spots. These are cafe au lait spots. So put two and two together. This is a case of neurofibromatosis type 1. With incidentally, he had nystagmus also. So we got an MRI brain and orbit done. We also referred this child to the pediatric neurologist, and we have advised him to come for family screening. He also has one younger brother. We have advised him to advise them to come with their family, parents, and the younger sibling as well. So coming to neurofibromatosis, we have read this during our pathology and MBBS days as well. There are two types, 1 and 2, the most common being the NF1. We see this in 1 in 2,700 to 3,000 live births. It occurs due to mutation in the NF1 gene on chromosome 17 and has an autosomal dominant mode of inheritance. And there are clinical criteria which have been defined by the National Institute of Health. What are these criteria? Cafe au lait spots, at least 6 or more. If you're dealing with a prepubertal child, they should be at least 5 millimeters or more in diameter. If you're dealing with a postpubertal child, then more than 15 millimeters in diameter. They should have neurofibromas, 2 or more dermal or 1 plexiform. Skin fold freckling, which could be axillary or inguinal. They could have optic nerve gliomas, leash nodules, 2 or more at least of leash nodules. Bony lesions, which could be sphenoid wing dysplasia or pseudoarthrosis of the long bones, or they could have any of the above criteria with a first degree relative with NF1. So if you say tomorrow this family comes and his father has NF neurofibromatosis and this child just has say leash nodules, you know for sure you're dealing with neurofibromatosis type 1. So it has a whole spectrum of findings. So as I mentioned, ocular findings could be leash or choroidal nodules. You could have cutaneous findings like cafe au lait spots, intratriginous freckling, which is nothing but axillary or inguinal freckling. They could have dermal neurofibromas. They could have cardiac malformations like coarctation of aorta, pulmonary stenosis, moyo disease. They could have aneurysms. They could also have certain oncologic findings as well, which could be benign and malignant peripheral nerve sheath tumors and optic pathway gliomas. You can have musculoskeletal findings in the form of sphenoid wing dysplasia and pseudoarthrosis of the long bones. So putting everything together, what did we go through today? We saw 2 cases of cataract in a child, which ended up being congenital rubella syndrome and Lowe syndrome. Lowe syndrome, we also learned that their first presenting symptom is muscle hypertony. They can have renal findings. We saw a case of ectopia lentis with Marfan syndrome. Then we looked at the small fold on the capsule, which was actually a case, or the capsule of the lens, which was actually a case of Alport syndrome. And we saw a case of aniridia. In the posterior segment, we saw the morning glory disc. We also saw a case of optic disc hypoplasia. We learned about how these discs can also be associated with CNS malformations, endocrine issues, and why it is important to look at them. We saw a case of syndromic RP and Bardet-Biedl syndrome, and then we saw a routine or anything but, which was a case of neurofibromatosis. So I'd like to conclude by saying that as ophthalmologists, we are actually uniquely privileged to have a chance to see some children. It's not necessary that we are pediatric ophthalmologists. A lot of time children are brought to us in the clinics and they could have routine refractive errors to some posterior segment pathology, which can have systemic involvements. And this is where detailed history taking and careful examination becomes vital. It can really help us. a lot of times we get flustered because we probably don't know all parts of a syndrome. It's not important, it's not necessary. What is important actually is to know when to suspect one. And please refer and take help from other specialties when needed. So with that, I would like to end my presentation. I would like to thank you all for your patient listening, and more importantly, I would like to thank entire iFocus team for giving me an opportunity to speak on a topic which I enjoy looking at in the clinics as well. Thank you very much for your patient listening.
Thank you, sir. Thank you so much. Your love and passion for this particular topic truly reflected in your class today. I think there are some questions from our audience. Does How does the timing of an embryological insult relate to specific ocular anomalies in congenital syndromes?
Yeah, so most of the times it is the damage that occurs in the first trimester because, as we know, the organogenesis occurs in the first trimester. So if there's any history, say, of infection, fever, it could be UTI or some drug intake that has happened, alcohol or drug abuse that happens in the first trimester, almost always these will have the child will have some congenital malformation. And that's why this history becomes very important to take because sometimes what happens is in our society somehow we are not very we have come across families who are not very open. They would have hidden certain facts from their partners, so they don't want to reveal everything. So sometimes you need to probe. You may have to separate and take history. And first trimester, anything in the first trimester, you're rest assured that you will find something in the child. It's just important to look for it or refer. If we are not in a position to look for it, please refer the child to a pediatrician or somebody who can look for it.
Sir, as doctors, we are in a situation in a lot of times where a lot of our colleagues or patients might say, like you said, they cannot open up to the families or their partners. So a lot of time they realize their pregnancy much later into the first three trimesters where they may have already had a history of alcohol or drug intake. So since this is so commonly known to cause syndromic effects in the fetus who's yet to be born, is it advisable that they should undergo proper legal abortion in such cases if it's that common? I mean,
Um,
because these are questions which are asked very commonly to doctors because by non-medicos.
See, I honestly, I don't think I'm in a position to answer that because as a doctor, I think as a doctor, what we should do is tell them. Obviously, their obstetrician and gynecologist is there to do all the scans and help them out with the scans. This many times anomaly scans are done and they can guide. I think we need to educate. Our role comes in education.
Right.
Right from the time we see that they're pregnant, tell them what to do, what not to do. If they are somebody who social smoking and alcohol intake is there, I think we should be bold enough to tell them not to do it. To tell them that to educate them that there can be issues with the child, the unborn child. I think that is our role. I don't think we should comment on whether abortion there should be an abortion decision taken. I don't think that is our call as ophthalmologists. I think our call is to guide them, let them meet their obstetrician, anomaly scan, go by the anomaly scan, and then along with I think the entire family and the obstetrician, they need to sit together and discuss that. As ophthalmologists, I don't think it is our place to actually advise that.
So
That's
we
my
can just
personal
refer
view.
them
Yeah,
to
yeah,
to an OBGY who might be a better person to guide them.
exactly.
Okay. So how do ocular features help differentiate between genetic syndromes like Marfan, Stickler, and Ehlers-Danlos?
So Stickler syndrome, it's very, very, very characteristic. You will have high myopia. You'll have those facial anomalies which I spoke about, and the vitreous. If you see that beaded vitreous with high myopia, it's clear cut. You don't get the type of myopia. See, Stickler syndrome, what you get if you look at the fundus, extremely tessellated fundus. Whereas in myopia, you can have lenticular myopia only, where because of the shape of the lens, you have the high myopia, whereas the fundus may not be very tessellated. And the systemic findings, so your mitral valve prolapse, aortic root dilatation, those kind of things. Ehlers-Danlos syndrome is similar but different in a way because they have a lot of hyper mobility kind of things. So if you ask them to kind of bend their wrist, they can completely bend it backwards. They can pull their skin, very very elastic skin. They can pull their skin. There are different type of Ehlers-Danlos. Like if you look into the classification of Ehlers-Danlos, there is vascular type, many different types. So they are similar when it comes to Ehlers-Danlos and Marfan's. Both can have ectopia lentis, but systemic findings are different. So again, I think our role is, yes, you have ectopia lentis, you need to get tested for this, and this. We feel you have Marfan syndrome, get a genetic test done, and then refer them to a specialist, a pediatrician, cardiologist.
Yes, so that brings me to the next question. Since a lot of postgraduates are still working in government hospitals, they want to know how can we manage syndromic children in setups where there's no access to geneticists?
Yeah, see, like I said, we don't actually need to identify syndromes. Our role is to first pick up, is this a routine case? Are there a few red flags that tell me this is not a routine case? Okay. If you identify a few red flags, then I think the time has come where even if we are working in government hospitals, we should have, if our government hospital doesn't have, say, somebody, a pediatric, a pediatrician who is specialized in genetics, or nowadays there are a lot of doctors who are specialized in syndromes. So if we have access to them, we should. Their time has come to actually have tie-ups with them and refer to these specialists. There are many doctors who are really noble enough to say that though they work in a private space, they would actually, for a patient who comes from a government hospital, they will go out of their way to help them. So I think it is time to have those kind of tie-ups between the government and the private sector as well, where a referral can be done and taken care of. As if we are working, say I'm a postgraduate and I see a case today which is, say, Lowe syndrome, a child with Lowe syndrome. Okay, uh, generally a pediatrician will be able to diagnose this. Okay, once he diagnoses this, the next information has to go to the anesthetist, because the anesthetist needs to know that this child is hypotonic, and you might have, if it's posted for surgery, there might be issues which need to be dealt with at the time of intubation, extubation. If they are prepared, they can take care. You don't need to necessarily refer it to a geneticist. So not all cases need to be referred to a geneticist. What we need to know is what are the clinical features, what are these systemic issues, what problems can they cause, and how can we prevent these problems from happening, when especially when we need to take them up for surgery.
Right. I think this is a more real life practical approach, especially in resource limited settings.
Correct. Yeah. Yeah.
Also, okay, so then, so most in cases where we have poor fundus view, the investigation of choice is the ocular ultrasonography and OCT. But how much information can we really get from an ultrasonography, without doing where we don't have any view of the fundus? So where can we really reach in our approach from just a USG or an OCT?
See, if we see what ultrasound, what does it tell us? It tells us retina is attached or no, and maybe if there are some, something floating around the vitreous, we might come to know. Uh, Poor fundus view, I can think of mainly maybe three scenarios. One is a child with leukocoria, a
Mm.
child with a poorly dilating pupil, like say Marfan syndrome. Marfan syndrome, we know the pupil dilates very poorly. So in these cases, whatever little inspection of the fundus we can do, we should do. Apart from that, do an ultrasound. At least it will tell us, okay, the retina is attached or no. If the retina is detached, then we have to refer it to our colleagues in VR. Nowadays, we have these non-mydriatic cameras. So if these non-mydriatic cameras are there, they do a good job of taking a retinal photograph, which can give reasonably good information. So it's it's working to the best of our ability with whatever limited we have. And then if needed, as I said, I don't think we should feel ashamed to refer cases to a place which has more facilities to take complete care of the child. In fact, when you talk to the families and tell them that, see, we have certain tests, these tests are limited, but you may need more tests. So I'm sending you to a place which has more tests. Once those tests are done, if you want any help from us, you can come back to us. They're actually very appreciative. They know that you're not trying to cheat them, you're actually wanting the best for them. So they will actually appreciate it. So I don't think we should be ashamed to refer cases.
Yeah. So a USG will, the information about whether the retina is attached, it's on or off, is most crucial to get from
Yeah,
a USG.
crucial. Yeah. And
Calcification
again, yes,
seen from
calcification,
USG.
because retinoblastoma is definitely not something you would want to miss. So things like that.
Okay. Okay. So in case the first child is affected, how important is the role of choriovilus sampling in a second child?
See, if the first child is affected, I think what is more important is you send the entire family to a genetics department. In your genetics department, you have genetic counselors who will do the pedigree charting and the clinical phenotype. What is the clinical phenotype you are dealing with? Are you dealing with, uh, since we're talking about the eye, are you dealing with, if you're dealing with Marfan syndrome, it's autosomal dominant. The chances of the second child being affected are quite high. So this information has to be given to the entire family after sitting with all of them and doing it appropriate genetic tests for all the family members. Again, chorionic villi sampling and all that, I think as ophthalmologists, we should not be in a position, we should not be in a position to advise that. We should not tell them, go get a chorionic villi sampling done. I think our role is to tell them, we are dealing with this particular clinical phenotype. This is a chance of transmission. So we are referring to you to a genetics person who will tell you more details about what is the chance of your second child being affected. And then working with a pediatrician and the entire obs-gynae team and all that, that decision can be and should be taken.
Um, so how do you distinguish between isolated developmental ocular anomalies and syndromic causes in absence of overt systemic signs?
Whenever in doubt, over-investigate. So supposing now there's a case of optic disc hypoplasia. Okay. Now theoretically, if you see unilateral optic disc hypoplasia, it is isolated, and bilateral is there's more of a chance of systemic features. But there is if you look at the statistics, there is a chance that even isolated could be associated with systemic. So our job is to investigate them. We're not losing anything. If the MRI comes normal, the endocrine workup comes normal, that's very good. Everyone is happy, family is happy, we are happy. So I think if wherever you cannot differentiate, there's no clear-cut sign. Honestly speaking, there is no clear-cut sign. I think if you have that clinical suspicion, you must go and investigate. You should. I think that is, as I said, that is when we are actually doing complete justice to the child who has come to us.
Okay, so how do syndromes like Mobius or Goldenhar impact ocular motility, and what surgical considerations arise from it?
See, Goldenhar syndrome on its own, it depends upon two things. One, the limbal dermoid that's there. How big is this limbal dermoid? Oftentimes, you'll see just tiny dermoids just away from the limbus. They will not do anything. Apart from being a cosmetic blemish, they don't do anything. But you could have these large limbal dermoids sitting at the limbus, tear film deficiency, very high astigmatism. They need removal. Okay, if they're affected, if there is a Duane retraction syndrome that is accompanying this Goldenhar syndrome, then you need to see Duane, like any other case of Duane's. Is the primary position deviation something that is very obvious, which is causing a manifest deviation? Is there a large abnormal head posture, upshoot and downshoot in Duane's that's there? Is it very large, causing a cosmetic blemish? So these are the three indications for surgery in Duane retraction syndrome, whether it's associated with Goldenhar or no. Mobius syndrome is a totally different story. Mobius syndrome, you definitely have a sixth nerve palsy. Obviously, there's a seventh nerve as well, but you have a sixth nerve palsy. Because of a sixth nerve palsy, you have an inward deviation of the eye, and almost a complete abduction limitation. These children need surgery. So you give them a little bit of amblyopia therapy initially, give them a lot of patching of the other eye, and when they are slightly old enough, they need a surgical intervention to bring their eye into as close to primary position as possible.
So there's a related question. In syndromes with congenital cataract, how do we balance early surgery versus risks like glaucoma or amblyopia?
So in most of the rule of the thumb in pediatric cataract surgery, especially very young babies, is the same. Bilateral cataracts, you have a little more time. Unilateral cataracts, you don't have much time, because unilateral cataract, you know that amblyopia risks are very high. So unilateral cataracts, normally you can operate safely around 6 weeks of age. Bilateral cataracts, you can wait up to 8 to 12 weeks of age till baby has gained a little more weight and the risks of anesthesia and all are that much more lesser to operate them. It does not matter whether it's a syndromic or a non-syndromic association, as long as you have got the full workup done. So you have done complete cardiac workup, you have referred to your anesthesiologist, they know what to expect. They know that, okay, this is a child with a VSD and these are the precautions we need to take. As long as you have kept them in the loop, the timing of surgery will not change based on the syndrome. It's more the overall health of the child and the unilateral versus bilateral scenario.
All right, sir. So, what are some glaring red flag ocular signs in a newborn or an infant that should prompt a pediatrician or even a beginner ophthalmology resident, for that matter, to think of a systemic congenital syndrome?
Definitely, the first one would be cataract, definitely. Okay. I think if you see cataract in a newborn, and with no family history, so the family members have not had cataract, always think of rubella syndrome, especially bilateral cataracts. Okay. Also keep in mind that child is a little, say 6 months, 1 year of age, and you're seeing white reflex. All the DDs of white reflexes to be kept and worked up. Apart from that, I would say if you see, don't ignore nystagmus. Nystagmus, sometimes we think it's infantile nystagmus syndrome, but it could be foveal hypoplasia, like that. If you see a little bit of, say, hypopigmentation, that's another sign of a syndrome. Albinism, we know albinism. Albinism is also associated with other syndromes, Kediak Higashi, to name one. So I think these are some of the things. The basic thing is, if you see a child who has, say, hair anomaly, dental anomalies, skin findings on the skin. It could be some capillary spots, growths on the skin, facial dysmorphism. Very you sometimes we cannot identify all the dysmorphism, but we just know by look at the child that there's something wrong in this child. The nose is a bit off, the two sides of the face are not symmetrical, the ears are very low or very high, retroverted or antiverted. These are all the signs that you may be dealing with a child with a who has an ocular issue with a syndromic underlying syndrome. We may be wrong, and we would be very happy to be wrong, but these are some of the pointers.
Okay. Thank you so much, sir. That was a very a deep dive into a topic not known very well to a lot of postgraduates. And I'm sure this is going to help a lot of them. After today's class, our next class would be on 18th of June for eye and thyroid disease by none other than the man himself, Dr. Santosh Navar, sir. Meanwhile, before we sign off, I would request my senior here, Dr. Ashwita, to please tell us a little more about physical eye focus from her own experience. Ashwata?
Yeah,
Ashwata?
yeah, I'm here.
Just a second. Yeah. Is my screen visible?
Yeah.
Yes, Dr. Ashwata, can you please tell us about your experience and a little more about physical eye focus for all our viewers here?
Yeah, hi everyone. So right now I'm doing my fellowship, but then 2 years ago I was also a part of this iFocus offline session. It's a 7-day crash course into everything that you need to know for your postgraduate exams and much more. it kind of wraps up everything in a nutshell, with details into each topic. The seats are limited. There are only 300 seats for this, and I think it's an experience for a lifetime, both in terms of exposure to academic, imbibing all the knowledge from the stalwarts of their, each of these sessions, as well as you get to meet a lot of people where you connect, both academically and personally, and they have multiple competitions where you can, be the star of the show or present the work that you see in such a large platform. It is definitely going to catapult you into a much better space after your postgraduate. So definitely go and enroll yourself from August 10th to 17th. It's going to be held at New Delhi this year, and we'd love to see you all there.
Thank you. Thank you, Dr. Ashwita. With that, we'll wrap up today's session. We'll see you all for the next session on 18th of June for the class with Dr. Santosh Shanawar. Thank you, sir. Thank you so much.
Thank you so much. Thank you. Bye-bye.
Good night.
Bye-bye.